Good afternoon, everyone. iTech India welcomes all the participants for today's NDLS session. We'll be covering advanced disease management in PLHIV today. We have with us today Dr. Ramesh Reddy Allam, sir. Sir is the public health specialist with Center of Disease Control and Prevention, India. All the question answers will be taken at the end of the session. Please feel free to put your questions in the chat box. Over to you, sir.
Yeah, thanks, Shweta. So, good afternoon, all. Today, we will discuss on this important topic on advanced disease management in patients presenting to our ART centers. Uh, and this topic is, I think, earlier a couple of experts have presented to you. So, I'll try to recap most of the things. And emphasis on this presentation will be to mostly take these learnings and apply in our ART centers of patients who visit us. Yeah, prior to that, we have 5 questions before this session.
Yeah. Kiran, sir, can we have the pre-test, please? So you want me to read out the question answers?
Yeah, yep,
Okay,
yep,
I'll do
yep.
that. I'll do that. Yeah, participants are requested to please attempt the pre-poll, that is the pre-test questions. There are 5 questions in all. Scroll through the questions and click on the answer of your choice. I'll read out the questions in the meantime. The first question is, what is the definition of advanced HIV disease among adults and adolescents? So the options are presenting with CD4 count less than 200 cells, presenting with CD4 count less than 200 cells, and WHO stage 3 disease. Third option, presenting with CD4 count less than 200 cells and WHO stage 3 or 4 disease. And the last option is children younger than 5 years of age who are not on ART. The second question is, what is the most common OI in HIV in India? Options are PCP, TB, toxoplasmosis, gastrointestinal OIs. Question number 3 is, which of the following is not included in package of advanced HIV disease management? First option is systematic screening for CRAG, fluconazole preemptive therapy for CRAG positive people without evidence of meningitis, rapid ART initiation, reimbursement of travel expenses case to case basis, and adherence counseling. You need to select which is not included in these 4 options. Fourth question is, which of the following statement is true for CPT, that is cotrimoxazole preventive therapy? CPT is not recommended in pregnant and lactating women. Initiate ART first and after 2 weeks start with CPT. Cotrimoxazole desensitization should be attempted in PLHIV with a previous severe reaction to cotrimoxazole or other sulfa-containing drugs. No specific laboratory monitoring is required in patients receiving cotrimoxazole. Last question. Following are the criteria for discontinue fluconazole primary prophylaxis, except person is adherent to ART and free of cryptococcal disease, fluconazole given for at least 3 months, CD4 cell count is more than 100 cells, and suppressed plasma viral load. That is, plasma viral load is less than 1,000 copies. You need to select the criteria for discontinue fluconazole primary prophylaxis, except. So you need to select the criteria which is not applicable. Requesting all the participants to please attempt the pre-poll. We have another 3 minutes for the pre-test. Please scroll through all the 5 questions and click on the answer of your choice. Requesting participants who have joined now to attempt the pre-poll. Requesting all the participants to please attempt the pre-poll. The questions are visible on your screen. There are 5 questions in all. Scroll through the questions and click on the answer of your choice. Only 22 out of almost 90 participants have attempted the pre-poll, requesting all participants to please participate. So we can end the pre-poll now.
Okay.
Yeah.
So I'll continue.
Yes,
Yeah.
sir, please.
Okay. Okay. So as I told you, the key objectives of this session is all of you should be able to again refresh or to think about what is the definition of advanced disease in both children and adults, and what is the need for advanced disease management. And we will try to go through each of the components of the advanced disease management package of care. So this all started, like, if you go back and see, there is several years we have been implementing the National AIDS Control Program, or globally there are many national programs that are being implemented in specific countries. But however, we see that there is a plateauing of death or the mortality or the AIDS related deaths that's occurring. So we already had missed the 2020 targets, okay, where we need to actually lessen it by 500,000 deaths. So things have not been so smooth. The plateauing effect is here. That means there is something we were missing. So there were several trials that had occurred during this period of time to understand why is the death or not being reduced over time. So the focus was more to be given on early detection, because people who present at the late stage will definitely have some consequences related to the outcome. So they may be presenting with a lower CD4 count. There may be more serious opportunistic infections, which will again relate to reducing the quality of life. Or even though the patient is on antiretroviral therapy, the drugs cannot act efficiently because of other malnutrition, other opportunistic infections that may be part the patient is undergoing. And there's an increased mortality and transmission to spouse or sexual partner is in there. So hence, you see that there is a gradual change in the guidelines. Initially, we were offering to only patients presenting with a lesser CD4 count less than 200. Then we tried to include somebody at 350, then 300, 500. And since 2017, it is treat all. So treat all is mainly to ensure that we are treating the patient as early as possible. That is, at diagnosis, we want to start the treatment. And this is one major element that you need to consider, that early initiation of treatment is again a good predictor of survival or longevity of life among patients with HIV. Then if you compare between patients who have a CD4 count less than 2000 and a greater than 2000 cells, you see that the mortality is relatively higher among those patients presenting with a CD4 count of less than 200. So then there is a genesis. Now it has happened that globally people started to look at why there is relatively higher mortality among these patients and what could be offered to these patients in order to reduce the mortality. And this graph again is talking about annually, if you plot the CD4 counts, okay, and you see that they're plotting the bars for patients presenting with a CD4 count less than 200. And 33% of them in low and middle income countries, if you see, 33% of them, while we start our antiretroviral therapy, we have such patients with a CD4 count of less than 200. And there is no much difference between patients presenting with CD400. So if you see 20% of our total patients presenting at ART initiation will have a CD4 count less than 100. So what it means is patients are presenting late, and there is an increased risk of mortality or morbidity, and we need to act upon this with whatever limited time we have in our hand in the form of a package of care. This is called as advanced disease management package of care. I don't think that this scenario is different from all people who are hearing today on this call. You can just use your chat box for half a minute and just put in the chat what percentage of your patients presenting to you, that is, of the newly initiated patients, how many of them have a CD4 count less than 200? Please give your center's response. Okay, in your center, what are you observing? Is it 10%, 50%, 30%, 45%? What are you observing in your center? Come on, use your chat box. Yeah, nobody has put anything until now. I'm giving you additional 30 seconds. Good. Salem, Dr. Umma Sahu, Prema. Yeah, there are only three people, man, who has attempted. I'm waiting. Okay, more or less, I don't know how many have. Others, I presume that you have not seen your data, or who are those patients. You may not even be sitting in your ART centers to understand what is happening and why this is. Okay, good. So majority of you are already saying that 50% of the patients who are presenting to you, usually you see them coming with a CD4 count less than 200. And yeah, 20 to 25%, 30%, right? So, but minimum you see somewhere between 25 to 50% is the range that we have seen, at least the responses who all have given. So now, among these patients, you will obviously observe that the mortality is higher among these group of patients, or your quality of care of the patient is deteriorating, that you can see. Now, what is that we have to do rapidly in order to prevent that excess mortality? Because of this is what the session is. Good. Now it is more and more important for all of you to listen to this and see what best we can do in our ART centers to prevent this excess mortality. Yeah. If you see again the median CD4 count at our ART centers, you see that in 2018, the median CD4 count is around 274. This doesn't mean that patients are presenting with this. No, it is a median of that. So there are other 50% this side and 50% the other side of presentation. So this is what is part of our guideline. If you have seen patients with CD4 count less than 200, 35% of our patients present with this. And between 200 to 349, 26%. And you see with the relatively higher CD4 count is only 20% of our patients are presenting with a CD4 count more than 500 cells. Now let us see what is the meaning of advanced disease management, or when do you call advanced HIV disease? For adults and adolescents and children older than 5 years. So see the definition. It is not including children less than 5 years in this definition. That means they will have something else. So for all of them who are more than 5 years of age, anybody presenting with a CD4 count less than 200 cells, or WHO clinical stage 3 or 4, or they can present with both or any one of these. So don't make your definition as CD4 count less than 200. Don't stop there. If somebody has a CD4 count of more than 200 cells, and if he has a stage 4 illness, can you categorize this patient as advanced HIV disease? If it is yes, you say yes in your chat box. If no, no. So the case for you is there's a male patient, age 20 years. He's presenting with a stage 4 clinical disease, and his CD4 count is 350. Now, will you call this patient as AHD or not? If yes, you say yes in your chat box, no, no in the chat box. Good. So basically, you can a patient can have both or any one of these. So don't just hit it hard on that CD4 count less than 200. But if somebody has an extra pulmonary TB, obviously the patient will be stage 4 and it's called as an advanced HIV disease. It includes both ART and those who interrupted treatment and who are returning to care. Now, this is very, very important. So, ADM package is not only for patients whom you are starting ART new, not just newly initiated patients. But if you have a patient who is already on antiretroviral therapy and he was a lost to follow up or a treatment interruption, and now he is coming back to treatment. So these patients also, if they have their latest CD4 count or whatever was their last CD4 count less than 200, you will definitely put on this package of care and see what all the patient needs to get. And all children younger than 5 years of age who are not already receiving ART and clinically stable, what is in the brackets is important, who are not receiving ART and clinically stable. Okay. All these patients should be considered as having advanced HIV disease. So, in simple words, children less than 5 years of age, if they are not on ART for more than 1 year, everybody of them should be considered as advanced HIV disease. Now, there is a question for you again. Say yes or no. Do we have different packages? That is, for everybody above 5 years, there is one package. Less than 5 years, there is one package. That is, for children, you have a different package of care or advanced disease package. And for adults, adolescents, more than 5 years, all of them you have different. If they are different, say yes. If they are same, say no. If the package is different for children and adults, you say yes. If it is the same, you say no. Yeah, good. Very good. So, yeah. So there are different packages. I may be giving you a small sort of questions, but these are all really important for all your center staff to understand that there are two different packages. There are when you call the child for advanced disease, when do you call adult adolescent greater than 5 years as an advanced disease? These basics should not go wrong. And how do you categorize a patient into advanced and not having an advanced disease? These are really important even before you know about the packages. Okay. Now you all know how to categorize patients, and it is not just patients who are newly initiated you should be categorizing them, but who have treatment interruptions and are returning to care. All of them will be part of this definition. And as you see, patients will have increased risk of either opportunistic infections or immune reconstitution or any other comorbidity. Frequent monitoring needs are there and economic burden to the PLHIV. So this is the importance of why these patient groups are important. Now, these are all different studies that they have been conducted to see for what is the mortality or the prevalence of these opportunistic infections and how they are. Now, one second. Yeah. Now, if you see the causes of mortality in advanced HIV disease, okay, you see that patients who have tuberculosis, cryptotoxo PCP in adults, these are, and in kids again, all those three things are there, but diarrheal and malnutrition wasting are the most common there. So the causes of mortality among advanced HIV disease patients, if you see, these are the most common cases. And again, these are the most common opportunistic infections which the patient presents to us. So now, what does this package of advanced HIV disease have in it? So, what is this package? So, this is basically a sort of differentiated care. If you talk in terms of person centered care, this is a part of differentiated care where we are trying to provide specific management to patients who most need those. That means these are a special group of persons who really require a specialized care from other patient groups. So here, this uh, advanced disease management package includes screening, rapid ART initiation, or the adherence support. These are three things which are part of this one. So it will include something related to screening from opportunistic infections, treatment of them or prophylaxis for them, rapid ART initiation, and intensified adherence support. So these are all the part of the package, and we will see under each of this what are the subcomponents that we have. The aim is to reduce the mortality and morbidity that we are trying to analyze. And the benefits have all been demonstrated in a well conducted clinical trials. And some program data is also coming out on if a country or if a state is using an advanced disease management package of care, are they able to prevent that excess death? Number one. Number two is, are they able to at least offer these components of care to everybody? So there's a lot of evidence coming out, and countries are being able to put this as a routine practice within their ART centers. Now, please remember these five. These are the components of the advanced disease management. So number one will be screening for active TB and prompt initiation of anti-TB treatment among those who are positive for TB or those who are 4-symptom negative, to initiate TB prevention therapy based on after ruling out contraindications, if any. So the first part of the story is related to tuberculosis screening, treatment, and providing prophylaxis to them, or TB preventive therapy. The second most common mortality that you have seen is from cryptococcus. So you want to really screen for it. So we use something called as a cryptococcal antigen screening test we have. It is again a sort of rapid point of care test. And fluconazole preemptive therapy is part of this. When I'll dwell further in the coming slides on what is the meaning of preemptive, what is the meaning of prophylaxis, what is the meaning of preventive. So there are three different things that we need to understand. And screening for cotrimoxazole prophylaxis, rapid initiation of antiretroviral therapy, and adapted adherence support and intensive follow-up. So even everybody in your center should understand that what is an ADM and what are the components of an ADM. And if you understand these five things, I don't think there'll be a problem in implementing them in your center. Now, theoretically, some people are not aware of this completely. And even if you are aware, you don't try to practice this. And these are all part of our current guidelines. I'm not saying anything new. These are all part of the current guidelines. So we need to now start practicing in all centers. Some of them are doing, I know personally few of them, but we need to make it as a habit routinely to practice advanced HIV management within our centers. And the goal is to reduce the morbidity and mortality, nothing else. So once you are aware that these are the five components, let us see what we are doing for screening and diagnosis of TB. I think in most centers, we are doing a 4-symptom screening, and all patients who are positive for 4S are subjected to CBNAT or any other investigations whatever warranted may be, or you send them for a radiological examination, or if you're suspecting an extrapulmonary TB, you would be sending them for an excision or taking an FNAC. So those are the things that we are routinely doing for four symptom screening. And so I know some centers who are also doing who are trying to increase the sensitivity of the screening by adding a chest X-ray to their algorithm, and then who are chest X-ray positive also, then you refer them to a for a CBNAT. Now this is a routine way of doing. But one thing what we need to remember is, in a patient who is having this advanced disease, the immune status is not so good, right? So the immune status is not so good. The they cannot develop that immune response immediately. So there's a lag in developing that immune response. So what happens is, you will not be able to, number one, have those typical radiological findings in a chest X-ray. Okay, X-rays are normal. And then your what is most common presentation among HIV patients? Is it extrapulmonary TB or pulmonary TB? So it is extrapulmonary TB, which is the most common presentation. But if you look at your own data, what it will show is pulmonary TB is higher. Now, it is not because the science is wrong, it is because you do not have that efficient tools to diagnose a person, to diagnose extrapulmonary tuberculosis. Okay. So your chest X-ray or the CBNAT, whatever you refer for cough, are all trying to catch pulmonary TB, but you do not have that efficient way of looking or screening for extrapulmonary TB. And patients with severe immunocompromised or advanced HIV disease usually present with extrapulmonary tuberculosis. So this is why I'm taking the discussion here is, I need to introduce you to something called as a LAM. So if you see what is a LAM, this is lipoarabinomen. This is a derivative from the cell wall of the mycobacterium, lipoarabinomenin. So this is a glycoprotein that you have there, and this is mainly excreted through the kidney. Okay, and hence, if there is a foci of TB anywhere in the body, if you are doing this urine test, okay, using this lateral flow assay, there is more chances that you will be able to screen more number of cases, and particularly for extrapulmonary TB. Okay, so that's why this is part of the screening tool and part of the diagnosis of TB. Why is it important? Because most patients present with tuberculosis, more number of deaths are with tuberculosis, and you need to identify more efficiently among these group of patients who really have extrapulmonary TB. So this is basically a point of care test. This is the lateral flow assay that we use, but it is not within the program now. So whenever it comes, that's what is part of the guideline. If you see, TB LAM is currently not available in the program. When and when it is available, we use it. But until then, you need to increase the screening frequency for tuberculosis, routinely do the four symptom screening as efficiently as possible. And you can use other tools that we have, either chest X-ray or any other minor surgical procedures that you have to use to send the samples. Then next screening test, we are going to look for cryptococcus. So this is again an antigen, cryptococcal antigen screening test. This again is a lateral flow assay where it is a point of care test. You can do this in the serum based test, or you can use it for a CSF. So whenever a patient's present to us, anybody presenting with a CD4 count of less than 200, okay, there you do a cryptococcal antigen screening if it is part of the program. If it is not, now we don't have it. So currently what we should be doing, I will come to you. But This is not available. If it is available, it is both serum based and CSF based a rapid point of care test that you can do. And one important thing is we cannot use CRAG, or it is shown from different literatures that it is not much beneficial among children less than 10 years of age. Usually we do not do a CRAG. Okay. Now we have seen screening. So patients have to be screened for tuberculosis. Patient has to be screened for cryptococcal meningitis. I have mentioned the tools, but if there's a limitation of tool, what to do, I'm coming next. Now there is a prophylaxis component. So I told you there is number one, screening. We have seen screening now. The second part now we are going to see is prophylaxis or preventive treatment. Now prophylaxis is cotrimoxazole prophylaxis. This is offered to all patients, not just less than 200, but less than 350. All patients should be there. And the same guidelines of the cotrimoxazole, when to start, when to end, whom not to give, if there is a sulfur reaction or a cotrimoxazole reaction, what to do, what are the alternative drugs, all that we can apply here. So it is no different from the routine cotrimoxazole that we are offering to patients who are between 201 to 350, whom we are offering cotrimoxazole. The same guidance holds good in both adults and children. But I'll just try to touch upon them at the end. TB preventive therapy. So this is INH for 6 months wherever you are giving, or it is 3 HP, or it is 1 HP wherever we are offering to patients. 28 days of INH. Okay. Here. It depends on which state you are or what is that regimen. But we have seen this in our previous sessions too. Okay. Then fluconazole preventive therapy for crack. So please remember. So preemptive therapy means the patient is not having any symptoms of TB meningitis, sorry, of any symptoms suggestive of meningitis. Okay, that's number one. Number two is there is no other screening that the patient has a cryptococcal antigen in the body. That is, you are not able to do, or it is coming negative. And if you have a CD4 count less than 100, so that is the clinching thing. Those patients should be offered a prophylaxis less than 100. So that is called as primary prophylaxis. That is, but if somebody is having a positive CRAG and then you do fluconazole, it is preemptive. And then we are talking of prophylaxis, even without any disease, just depending upon CD4 count or any other marker you are starting it, that is a prophylaxis. And you have something called a secondary prophylaxis, that is after you treat the condition you are giving secondary prophylaxis. Usually we come across secondary prophylaxis in the management of cryptococcal meningitis, in the management of TB, the management of toxoplasma, and there are some other conditions where you usually see this secondary prophylaxis. So you need to know preventive, preemptive, primary prophylaxis, and secondary prophylaxis. These are some of the common terminologies that you will come across while reading. Now, in the package of care, the other one is a rapid ART. So starting ART as early as possible is the best thing for a better outcome of the patient. Now, can you type in your chat where you will delay this initiation? Instances where you delay ART initiation. Some conditions, 2 or 3 conditions, if you can put it in your chat. Where are those conditions you are delaying ART initiation? Other than TB, other than TB. PCP, crypto, toxo. Yeah, some of you have put it crypto. Yeah. So just to be aware where it should be delayed a bit. And then all other conditions you need to do as rapidly as possible. And then the last part of the package is adherence support. This is a non-negotiable one. Regardless of the CD4 count, we do an adherence support. But patients with less than 200, we do a much more efficient way of doing. And hence, if you look at our operational guidelines, and some centers are doing this, that is, you're dividing your patients into A, B, and C category of patients. And all advanced HIV disease patients, in which category do they fall? Please put in the chat box. All patients presenting with an advanced HIV disease, what category do you categorize them under? I'm not talking about staging, I'm talking about the packages of care. Yeah, IGICHS, done it good. Dr. Badal, yes, A plus. So there are three packages: A plus, B, and C. So all patients presenting with advanced HIV disease are categorized under A plus. Good. Okay. Now this is the algorithm. This is present in your operational guidelines and in technical guidelines also. This is there. So what you should be doing first, immediately whenever a patient is presenting, you do a 4 symptom screening, and the counselors will look into the viral load of the patient, the CD4 count, or any symptoms the patient is presenting. The staff nurse will again do all the symptoms and signs, asking for that, looking for the vitals, and the medical officer will confirm if there is a 4 symptoms based on 4 symptom screening for a diagnosis. He or she will confirm the signs of serious illness. If there are very serious illness, okay, these are like cranial nerve involvement or advanced HIV disease, then they are immediately referred to an expert in the same institution or a higher center. This is important. Not everybody we can handle in our centers. So if you are seeing something like a danger signs or confirm some signs of serious illness, what are those we will see next? And if the CD4 count is available, and if the CD4 is suggestive of advanced HIV disease, then you will start doing the packages of care. So this is in brief about what are the different steps you will be following whenever you have a patient coming to our ART center. So if you zoom into each of these things, assessment of serious signs of serious illness, they are like temperature, respiratory rate greater than 30, heart rate greater than this, and you have an oxygen saturation falling down. So you look for these signs, and if these signs are there, uh, serious illness are confirmed by the medical officer, then they're referred for expert opinion. And if there are no signs, what you will further continue to do is you do a WHO clinical staging, okay? And if there is a child less than 5 years who is not stable, include them also here. Provide standard package of care. If not, you will be doing LAM, you will be doing an X-rays, CRAG, rapid CPT initiation. So all these will go as part of the advanced disease package. So in tuberculosis, as most of you have put out, as soon as possible within 2 weeks of initiating treatment, regardless of CD4 count, we initiate ART. With TB meningitis should be delayed at least 4 weeks. But however, within 8 weeks, we should initiate. That is, within 2 months, we should initiate. Now, cryptococcal meningitis, when it comes, we need to be really careful of the prophylaxis, but I'll talk to you mostly on fluconazole preemptive treatment to prevent the development of meningitis. If crack positive or fluconazole prophylaxis when crack test is not available and CD4 count is less than 100. So these are the instances where we are going to give a preemptive or a primary prophylaxis. So you have to remember, what is primary prophylaxis mean? Whenever there is no crag test available, okay, and the patient is presenting to you with a CD4 count less than 100, then you give a fluconazole primary prophylaxis. How much is that? What is that? We will see. But just understand there are three different things here. We are talking of primary prophylaxis, okay, and we are also talking of a preemptive treatment. That is, if somebody has a facility of crag screening test available, and if they are crag positive without other tests being positive for cryptococcal meningitis, then you start preemptive. And if somebody is diagnosed of cryptococcal meningitis, we put them on a full blown treatment. And after treatment, we provide secondary prophylaxis. So there are four things that you need to understand. So number one is a primary prophylaxis. Second is preemptive treatment. Third is a frank or a full-blown treatment for cryptococcal meningitis. And fourth is the secondary prophylaxis. So now, looking at the situation where you are in, now suppose I'm giving you one small case history. You just put in the chat what you will be offering. A patient is coming to you, had no signs of meningitis, has no headache, absolutely asymptomatic. Okay. But in your institution, you do not have the facility to do a crack screening test. Okay. But you had the patient CD4 count, and the CD4 count is 75. Now, what do you offer in this case? Is it a primary prophylaxis or a preemptive therapy? If it is primary prophylaxis, put 1. If it is preemptive therapy, put 2 in your chat box. Yeah, so this is primary prophylaxis, Baba. You are not, your judgment is regardless of the CRAG screening test. And this is what you all should be doing. This is part of the guidelines. So what guidelines says if you do not have CRAG, okay, and if a patient is presenting to you with a CD4 count less than 100 and has no signs and symptoms suggestive of meningitis, then you offer primary prophylaxis of fluconazole to this patient. Okay, this is not preemptive therapy. Preemptive therapy is when you have a crack test in your institution and your other tests to confirm meningitis are all negative, but only the crack is positive, then you give preemptive treatment and rest to our secondary and full blown treatment. Okay. I'm taking time here because most of the institutions, though you have fluconazole at your disposal, you are conservatively putting it and not using it for the patients who definitely need it. And this is for patients presenting to you with the CD4 count less than 100. Okay. Yeah. So there are certain challenges that you see with these patients because they have many opportunistic infections. The pill burden is high. So this is all again we need to tackle as the patients present to us. Yeah, this is the referral pattern I showed you. Okay. Now, what is rapid ART initiation? Rapid ART initiation is not just saying same day ART initiation. Rapid is according to our guidelines, within 7 to 14 days, we need to initiate antiretroviral therapy to these patients, and this is going to improve the survival and outcomes. And wherever possible, you could initiate on the same day. What? But that doesn't mean we miss out doing a clinical examination, doing the relative investigations, at least sending the samples for investigations. All this should not be missed out just by saying that we have started the patient rapidly on ART. Yeah, what you see in this graph, in this, is that the clinical outcomes, including reduced mortality, more patients are initiated on ART within 90 days, and retention in care at 12 months, viral suppression is better. So these are all compared. When you compare between standard care and the same day ART, these are all the outcomes, good outcomes that you are seeing. So rapid or same day ART has much beneficial. Right. These are all part of guidelines. I will not go into them. And I'm just touching upon prevention of opportunistic infections. So for PCP, we give again cotrimoxazole. For TB, you are giving isoniazid. See here, fluconazole. And again, secondary for PCP, secondary for TB, secondary for cryptococcal infections. So for cotrimoxazole, there's not much. Many of you are practicing it. The only one thing I see is that you're not giving a sufficient strengths of tablet. It is one double strength tablet that we need to be offering. Okay. Most of you are just some of your centers have only single strength tablet, and you tend to give one. Double strength is what we recommend. The second common thing where most of you miss down is if somebody is having an allergic reaction, 1 and 2 you can re-challenge. Usually 4 you don't re-challenge, but what you re-challenge is with dapsone. Again, dapsone is a sulfur component, so we need to be really careful on when a patient is desensitized and put on an alternate regimen. Cotrimoxazole prophylaxis, you restart whenever the CD4 count falls less than 350 cells. And when do you stop this? You don't immediately stop when the CD4 count increases to 350 after 6 months, but you wait for subsequent 6 months. That is usually if your two successive counts are more than 350, then you take a decision of stopping cotrimoxazole prevent prophylaxis. These are the doses. This is part of the guidelines. We'll not go into it. Among children, it is very important. Up to 5 years of age, regardless of the clinical stage, the child should be on cotrimoxazole. All HIV infected infants up to 5 years of age, regardless of CD4 count or percentage or clinical stage, all of them should be there. Okay. Next, cryptococcus. So this is important. See, I was talking to you of different tools that we have for diagnosis of cryptococcal meningitis. Number one is a point of care screening test. It is called as cryptococcal antigen screening test, a point of care test. The second is there are different ways that we could do it. You could demonstrate using it under a microscope. Okay. Indian ink is one highly specific test, not so sensitive. And again, you also have, you can do a culture, but again, not commonly available. The usual thing is CSF tap, what we do. And in CSF, you look for the biochemical markers to basically rule out between other meningitis. And then you can also subject CSF you can spin the CSF and you can subject it for, again, looking at for Indian ink, or you can also do a antigen screening test here, CRAG. So these are all the different things available. And you should remember that again, cryptococcal meningitis is very recurrent. Now, why is it recurrent? Is this is what I want you all to see. Primary prophylaxis indication is crack test is not available, but CD4 count less than 100. Fluconazole 100 milligrams once daily. Now, when do you stop this? If all of the following criteria is met, patient is adherent to ART and does not have cryptococcal disease, given for at least 1 year, CD4 count greater than 100, not 1000, and having a suppressed plasma viral load. If all these are there, then you discontinue that patient. So, when do you discontinue? If I just ask you an arbitrary question, you can at least simply say the patient should be on fluconazole at least for 1 year, CD4 higher, viral load suppression, ART adherent, not having cryptococcal disease. So these are the criteria that should be met before you stop cryptococcal primary prophylaxis. So please remember, for all patients presenting with a CD4 count less than 100, if you do not have an opportunity for crack screening, please initiate cryptococcal primary prophylaxis, but don't stop immediately after 1 month, 2 months, 3 months. No, this is for a minimum of 1 year. Okay, and then you take a decision to wean off after 1 year based on CD4 count, based on adherence, based on the viral load available. So this is one thing I want you all to remember. Second important thing, a prophylaxis or a maintenance therapy. This is again after successfully treating cryptococcal disease. Okay, then this is called as a secondary prophylaxis. That is a patient who had a disease or a diagnosis of cryptococcal meningitis and you have treated him for the first 14 days. After that first 2 weeks, whatever you call is called as a maintenance therapy. Okay, so this is all about maintenance therapy. And if you're just taking a decision based on a cryptococcal screening test and you don't have a disease, that is called as a preemptive therapy. It is very similar, 200 milligrams daily that you have to offer. So these are all the different packages of care that we have to basically sum up all the things. You remember that advanced disease management is a common presentation in our centers. Patients who are coming to our ART centers, almost 30% of them present with advanced disease. Advanced disease is categorized into for adults and children, or children less than 5 years of age. You categorically tell them that they are that they have advanced disease only if they are not on ART for more than 1 year. And then all of them more than 5 years of age presenting to you with a CD4 count less than 200 or has a stage 3 or 4 infection, you categorize them as advanced disease. Now, once you categorize them into advanced disease, you have to ensure 5 important things. That is, you screen them for tuberculosis, put them on treatment who is positive, and then give a prophylaxis for who are 4S negative. And you need to do a thorough screening with any other tools available to enhance the sensitivity of screening because we do not have LAM within the program. Second is cryptococcal. Screening for cryptococcus, do it with CRAG antigen. If it is not part of the program, then you do a very thorough or at least a primary prophylaxis for all presenting with CD4 count less than 100. And the third thing what we are doing is a prophylaxis with cotrimazole for all presenting with less than 350. Then rapid antiretroviral therapy initiation. Look at indications where you should not offer rapid ART. Remember those things. And then adherence is one major thing that we need to look out and follow up these patients. Now we have the pre-test. Huh?
Yeah, thank you so much, sir. So we'll take up questions first and then go for
Yeah,
the
yeah.
post-test.
Sure,
Kiran sir,
sure,
can you
sure.
please give mic access to everyone? Participants can either unmute or they can put their questions in the chat box. Any questions?
Mic access has been given.
Okay, thank you. Any questions from the participants? So we'll start with the post. Okay. So you want me to directly read out the answers?
I mean, if you have a poll, you can
Yeah.
do it, or
Yeah.
you
Yeah.
can
We
read
have a poll
anything.
now. Yeah, we have a poll,
Okay,
sir.
please
Oh
do.
yeah. Requesting Kiran sir to please put up the poll. Okay. Now the poll is visible on your screen. Participants are requested to please attempt all the 5 questions. Scroll through the questions and click on the answer of your choice. Requesting all the participants to please attempt the post test. We have around 150 logins, requesting everyone to please attempt the post test. Click on the answer of your choice. Meanwhile, if there are any questions, participants can unmute and ask questions also. We have another 2 minutes for the post test, and then we'll take the feedback form. Thank you so much, sir, for facilitating this session. Sir, we won't keep you waiting. We'll
Okay,
continue
thanks.
with the
Thank
post
you.
test and then the feedback form. Thank you so much, sir.
Thank you. Thank you. Yeah, bye.
Bye.
Thank you all.
Requesting all the participants to please attempt the post test. We'll keep it for another minute. Uh, Thank you for the post test. Kiran sir, can we run the feedback form now? Yeah, the feedback poll is now visible on your screen. Participants are requested to scroll through all the 5 questions. This is another set of questions. Please scroll through all the 5 questions and give your feedback. Requesting all the participants to please attempt the feedback poll. This is another set of questions. Meanwhile, I'll just quickly tell you the answers for the test. Kiran sir, is the screen visible?
Yes, ma'am.
Yes, thank you. So the first question was, what is the definition of advanced disease, HIV disease among adults and adolescents? So the answer is presenting a patient presenting with CD4 count less than 200 and WHO stage 3 or 4 disease. The second question was, which is the most common OI in HIV in India? The answer is TB. Third question, which of the following is not included in package of advanced HIV disease management, that is ADM? The answer is reimbursement of travel expenses, case to case basis. The fourth question was, which of the following statement is true for CPT, that is cotrimoxazole preventive therapy? And the answer is no specific laboratory monitoring is required in patients receiving cotrimoxazole. Fifth and last question, following are the criteria for discontinuing fluconazole primary prophylaxis, except the answer is fluconazole given for at least for 3 months. Kiran sir, we can end the feedback poll. Thank you to all the participants for joining in and for the interactive session. Thank you for your answers in the chat box. We'll conclude the session now.